Tackling the wider determinants of health. Before I introduce our speaker, just a couple of quick housekeeping reminders to run through. Our presentation today is scheduled to run until 10:45 and we have time dedicated to questions at the end. The session is being recorded, so please remember to keep your microphone muted so we don't pick up any background noise. And if you are asking a question when we get to the Q&A, please feel free to either pop up your hand or put something in the chat. The slides from today will be emailed out after the presentation, along with the recording and an evaluation form, which only takes a minute or two to complete and really does provide us with valuable feedback. So please do take the time to send that back to us. For anyone watching the recording back, if you want to offer any thoughts, there'll be a QR code at the end of the YouTube recording, which will take you to the evaluation form. So please add your thoughts that way. So on to our speaker, Samina Sheikh. Samina is a Principal Public Health Intelligence Specialist for Merton Council, which means she is responsible for managing, analysing and interpreting public health data. With this data evidence, Samina is able to advise decision makers how evidence can best be used to inform policy and strategy, which reflect the needs and priorities of Merton residents in order to improve their health and well-being. As you'll hear, all of this links with tackling inequalities around the wider determinants of health. And today, Samina will illustrate some of the approaches Merton have taken by focusing on the areas of environment, housing and child poverty. So Samina, I'll now pass on to you.
Thank you, Nicola. As Nicola has said, my role focuses on the data, whereas the practice and delivery of interventions is carried out by others in the team. I hope my presentation will give you an insight into the work we are doing in Merton. So while I'm not an expert in delivery, I will cover how the data is informing strategies. Next slide, please. Here's an overview of what I'm going to cover in today's session. I will look at the terminology around what inequalities and wider determinants are, the Marmot review and the Dahlgren and Whitehead model, and how they link into health inequalities. Some of the health inequalities we face in Merton, but focused on wider determinants, and some examples of the approaches we are taking in Merton to tackle inequalities. Next slide, please. The wider determinants of health are a diverse range of social, economic and environmental factors which influence people's mental and physical health. These factors are influenced by the distribution of resources which shape the conditions of daily life. What we mean by this is that variations in the systems and experience people are born into, live and age, have an impact on their life expectancy and years of ill health. Health inequalities are the avoidable and unfair differences in health outcomes experienced by different people because of factors such as the wider determinants of health. An example to illustrate these points could be the quality of the built and natural environment a person lives in, meaning that there may be variation in things such as air quality, the quality of green spaces they have access to, and the quality of their housing. All of these factors can have a direct impact on a person's health, and yet they are not the result of anything to do with individuals' behaviours, genetics, or medical care. If a person lives in an area with high levels of traffic pollution, has no green spaces nearby, and lives in poor quality housing, they suffer an inequity compared to someone who has constant access to clean air, who can easily access a well-kept park for exercise and to socialise, and who will return to a warm, decent standard of housing. The key aspect to all of this is that the health inequalities mentioned in the example are all avoidable because they are not natural, but arise from societal conditions which could be reduced or eliminated. They are also unfair because they are not random. They consistently occur across certain groups and they could be prevented. Next slide, please. The Marmot review titled, the Marmot review titled Fair Society, Healthy Lives looks at health inequalities in England and was published in 2010. It proposes an evidence-based strategy to address the social determinants of health, the conditions in which people are born, grow, live, work, and age, and which can lead to health inequalities. It draws further attention to the evidence that most people in England aren't living as long as the best off in society and spend longer in ill health. The report proposes a new way to reduce health inequalities in England post-2010. It argues that traditionally, government policies have focused resources only on some segments of society. To improve health for all of us and to reduce unfair and unjust inequalities in health, action is needed across the social gradient. The key to Marmot's approach to addressing health inequalities is to create the conditions for people to take control of their own lives. This requires action across the social determinants of health and beyond the reach of the NHS. This places renewed emphasis on the role of local government, who, along with national government departments, the voluntary and private sector, have a key role to play. When the Marmot Review 10 years on was published, it showed that life expectancy has failed to increase. Health inequalities have widened overall, and the amount of time people spend in poor health has increased. Key points to note from the report are: the more deprived the area, the shorter the life expectancy. This social gradient has become steeper over the last decade. There are marked regional differences in life expectancy, particularly among people living in more deprived areas. Mortality rates are increasing for men and women aged 45 to 49, perhaps related to so-called deaths of despair, like suicide, drugs, and alcohol abuse. Child poverty has increased, children's and youth centres have closed, funding for education is down. There's a housing crisis and a rise in homelessness. People have insufficient money to lead a healthy life. Next slide, please. The Dahlgren and Whitehead model of health determinants here describes the things I have talked about and how they come together. So, personal characteristics occupy the core of the model and include sex, age, ethnic group, and hereditary factors. Individual lifestyle factors include behaviours such as smoking, alcohol use, and physical activity. Social and community networks include family and wider social circles. Living and working conditions include access and opportunities in relation to jobs, housing, education, and welfare services. General socioeconomic, cultural, and environmental conditions include factors such as disposable income, taxation, and availability of work. Next slide, please. Here you can see some Merton maps. The point I want you to take that the east of the borough has higher inequalities on a number of measures. On the top left, you can see a map of deprivation, which is higher in the east of the borough. In the top right, you can see that we have 14.2% of people living in socially rented accommodation, and again, this is higher in the east of the borough. Bottom right shows the same picture around long-term unemployment, and in the bottom left, the darker bars in the graph show wards with higher numbers of homeless applications, which are primarily those in the east of the borough too. Next slide, please. Here are some more maps. The top left shows aggregated crime counts, which are slightly higher in the east of the borough. Top right, deprivation in children is higher in lower deciles, meaning higher deprivation. Bottom left, children living in low-income households range from 11 to 18% and is higher in the east of the borough. And the bottom right shows the proportion of smokers is higher in the 2 PCNs in the east of the borough too. Next slide, please. The first example of how we are tackling a health inequality in Merton that I will go through is child poverty. You can see some facts related to this on the slide. So in Merton, just under a fifth of our population are children aged 0 to 15 years old. Of that number, Merton has an estimated 15,700 children living in poverty, which is approximately 30% of all children in the borough. We don't have data on household income after housing costs at local authority level. However, we do know that factoring in housing costs increases the number of children living in poverty. Other measures to understand deprivation levels are the number of children eligible for free school meals can be used as a proxy measure for children living in poverty. Merton has almost 7,300 children who are eligible for free school meals. The number of children in households receiving universal credit replaces 6 benefits and therefore could be used as a proxy measure for children living in low-income households and deprivation. In May 2025, approximately 16,500 children in Merton were in households receiving universal credit. Between April and September 2025, 421 households with children, that is a total of 748 children, either presented to the council as homeless or at risk of homelessness. A little about why child poverty is such an important inequality to tackle. Academic studies show that those living in poverty have worse educational, health, and economic outcomes. Those that experience child poverty are at a higher risk of going on to live in poverty in adulthood, as the combination of disadvantages can entrench poverty through generations. Inequality in early childhood affects cognitive, emotional, and physical development, but there are opportunities to address this through evidence-based early childhood interventions. Merton's health and wellbeing strategy emphasises the crucial role of the early years, childhood and adolescence, to lay the foundation for lifelong health and well-being, and it utilises the 8 Marmot principles for reducing health inequalities. In Merton, we know that there are persistent significant health inequalities and disparities between the east and the west of the borough, as you saw on the earlier slides. Life expectancy and healthy life expectancy remains lower in the east of the borough, where deprivation is higher. Children in poverty have worse educational attainment. Those in poverty have higher levels of obesity. And people living in the least affluent areas have poorer access to safe, high-quality green space, good housing conditions and employment, and greater exposure to crime, noise pollution, and toxic air. Next slide, please. I want to tell you about the approaches we have taken in Merton using both national policy and our own data to address child poverty. This slide references the UK government's child poverty strategy, which is a strategic framework designed to tackle child poverty through a range of measures. The key themes within the document are increasing families' income through benefits, parental employment, and looking at overcoming barriers to increase income. Saving families money by reducing the costs of essentials such as housing, energy bills, and food. Increasing financial resilience to enable families to build savings and reduce debts, and tackling the impacts of poverty by improving access to services which will help to improve outcomes. This strategic framework encompasses addressing both the long-term causes and the short-term impacts of poverty in order to comprehensively address the issues. The longer-term measures might include improving educational outcomes, adult skills and learning, more affordable housing in the borough, and so on. Addressing the root causes of poverty will take time. Therefore, shorter-term measures will also be needed to support the lives of children living in poverty and making sure that children don't go hungry on a day-to-day basis. It is clear that certain aspects of the strategy will fall inside local government's remit, and others will be beyond the control of councils due to national policy or the international economic context. For example, for income, national policies on the levels of benefits and benefit caps, job market and wider economic context, national policies on minimum wages and national policies on free childcare are outside local government control. But supporting benefit take-up and benefit maximisation, providing additional hardship financial support, upskilling residents for the job market, building relationships with local businesses and signposting to free childcare are within local government control. Around costs, as an example, inflation causing cost of living to rise, the housing market and wider economic context, as well as national policies resulting in not enough affordable housing, are outside local government control. However, support with council tax, signposting to support with other bills like water and energy, and supporting the development of more social housing is within local government control. And lastly, financial resilience, such as policies relating to income and benefit levels, are outside local government control, but signposting to debt advice is within local government control. All of these aspects of the strategy should take a multi-agency approach. There are a huge range of partners working to alleviate the impacts of poverty and support families out of poverty. These range from voluntary sector organisations running food banks, schools supporting children and families day to day, organisations running debt advice services, and faith and community groups. Next slide, please. The previous slides, including the first slide on child poverty with the data, describe the extent to which child poverty is an issue in the borough and the numbers of children affected. Merton is developing a child poverty strategy and has formed a delivery unit to focus and deliver on the child poverty workstream. Public Health has provided input, including data using the Merton Story, which is our joint strategic needs assessment, and the Health and Wellbeing Strategy, which has facts and information, as well as actions that focus on child poverty. Merton is also working with a range of partners that work with children. I'll give you some more specific information about the range of services that Merton is already delivering, which will go some way to tackling child poverty and the strategy that is being worked on. So for increasing families' income, we have Employ Merton, emergency assistance grants, household support funding, including vouchers for families in receipt of council tax support, cash grants to care leavers, those under special guardian orders and in foster care, and fuel vouchers. We have benefit maximisation and advice, adult learning, including English speakers of other languages, signposting to free childcare, and the Living Wage Employer Grant Scheme. For saving families money, we have council tax support, the Warm and Well programme, signposting to financial support services, discretionary housing payments, energy advice delivered via voluntary sector partners. For increasing financial resilience, we have the Local Welfare Support Scheme, Merton Young Saver Scheme, specialist debt advice delivered by voluntary sector partners, extensive cost of living advice and signposting and cost of living events. And for tackling the impact of poverty, we have support to families like family hubs, holiday activity and food programme, food support via community fridge, holiday-free school meal vouchers, free sports and wellbeing activities, youth centres, children's centres and libraries. We need to better understand the take-up of these services. Are we reaching all of the families in poverty? Whether there are any barriers to take up, such as low awareness of programmes. the impact of the services, and whether there is a differential in impact for the most deprived vulnerable groups. Also, we can learn from others, such as the London Borough of Camden appointed the Institute of Health Equity to produce a child health equity data audit in March 2025. This was the first step in their Raise Camden programme, which seeks to improve the childhood experience of those living in deprivation in the borough and raise the healthy life expectancy of residents living in poverty. Recommendations from this report are being used to develop a series of priority work programmes. Further work is required to learn from other councils taking interesting approaches to tackling child poverty. Next slide, please. My second example is about physical inactivity and the environment. This has been taken from our annual public health report, Merton on the Move, which focuses on physical inactivity. I have included some data that focuses on the environment on the slide, but if you want to see the full range of data, a link to the full report is available on the resources page at the end of the slide deck. The data and evidence demonstrates how physical inactivity affects different age groups and what the recommended levels of physical activity are, as well as the barriers people face. Changes in the physical environment alone may not be enough to help us be active. It may also be necessary to change our relationship with our neighbourhoods. For example, addressing fears about safety, encouraging community support for activity, and changing beliefs and perceptions of physical activity, as you can see in the graph on the slide. Merton's local plan is guiding improvements to Merton's built environment, including designs to create physically active promoting environments. Incorporating active design principles is recommended to create the environments which will encourage us to be active. The features of actively designed neighbourhoods are networks or multifunctional open spaces that are accessible, joined up, and high quality open spaces such as parks, green space, and civic space. Walkable communities, which are neighbourhoods designed so that everyday facilities and recreational spaces are within easy walking or cycling distance. That connected active travel routes are a safe, continuous and accessible network of walking and cycling routes linking key destinations. High quality streets and spaces for safe, attractive and well-planned environments with high quality materials, appropriate street furniture and clear signage. Activity infrastructure that supports physical activity from workplaces and leisure centres to parks and public spaces. Well-maintained, high-quality flexible spaces designed for activities that are well-maintained, monitored and adaptable to changing needs. And encouraging people to be more physically active and increasing the awareness of activity opportunities within a community. Also, one of the most positive aspects of Merton's environment is the number and quality of parks and open spaces, with residents on average just less than a 5-minute walk away from a park, open space or public garden. 11% of Merton's trees are street trees that provide the shade necessary to encourage street walking and wheeling in the increasingly hot summers. Gardening is an all-round physical activity that can happen in back gardens, allotments, on balconies, or in parks, or as part of a gardening club. Every public transport journey starts with walking or wheeling, so combining walking and public transport as part of active travel is a good way to increase activity levels in our daily lives. Merton residents generally benefit from access to a good choice of public transport options, including 2 tube lines, 2 mainline train options, the tram, and numerous bus routes. But not all areas of Merton are equally well connected, as you can see in the map. Next slide, please. Merton Council is already prioritising many interventions and initiatives to increase physical activity. using a wide range of plans and strategies to improve and promote a more active and healthier lifestyle amongst its residents. Merton's local plan is guiding improvements to Merton's built environment, from new developments, homes, transport to sustainability. The local plan states that the council will deliver well-designed and resilient neighbourhoods which support the needs of all of Merton's communities through creating spaces and environments that are accessible, inclusive, child-friendly, intergenerational, and promote active travel choices, enhance the feeling of safety and security, and create spaces where people can come together to relax and socialise. Approaches included in the local plan, which are particularly designed to create physical activity promoting environments, include high quality design of buildings, places and spaces. This creates attractive environments that support sustainable communities. Design should consider the arrangements of buildings and how they relate to their surroundings and function as part of a wider area. 20-minute neighbourhoods. This approach is about creating attractive, interesting, safe and walking environments in which people of all ages and fitness can actively travel for short distances from home. The features of a 20-minute neighbourhood are shown in the figure. Healthy streets approach. This focuses on making our neighbourhoods healthier, more sustainable, safer and more connected. Dementia-friendly communities. This approach prioritises in ensuring environments are designed to suit the needs of people with dementia. Active design principles require developers to adopt physically active design principles as part of development proposals. Health impact assessments. These are a method for judging the health benefits or harms of a development, including impacts on physical activity. Next slide, please. My third example is on smoking. Merton has the 6th highest smoking prevalence rate in London, with fluctuating trends. The Tobacco Control Plan sets out government policy to address inequalities in people who smoke, live in social housing and are in routine and manual occupations, as they have the highest levels of smoking, with 1 in 3 people living in social housing being a smoker and 1 in 3 people working in routine and manual occupations living in social housing. As the slide shows, Merton's highest prevalence of smokers are those in routine and manual occupations. The literature and evidence tells us that people living in social housing find it difficult to quit smoking, as they are more heavily addicted, and smoking behaviour may be considered as more of a societal norm. More efforts are needed to raise awareness for healthy lifestyle choices in social housing residents to take more control over their health, as they are disproportionately affected by health impacts and inequalities, losing 1/8 of their disposable income on smoking costs. Behaviours such as smoking make up a person's lifestyle factors, as well as social and community networks, which include family and other social groups. In Merton, local level data shows that smoking is more prevalent in individuals aged 25 to 34 years. National data tells us that 1 in 5 unemployed adults were more likely to smoke, and people who have no qualifications are 3.9 times likely to smoke than people having a higher qualification. Those in social housing are 3.8 times more likely to smoke than those who are homeowners. People who are long-term smokers are 7.5 times less likely to be employed due to the causes of disability and illness caused by smoking. Next slide, please. To address the problem around smoking, Merton uses national and regional policies. Being smoke-free by 2030 to create a smoke-free generation and the NHS long-term plan aimed at supporting people in contact with NHS services to stop smoking are based on an evidence-based model to making England a smoke-free society by 2030 and are the national policies that Merton uses. Regional policies are the Stop Smoking London programme, which is the public-facing identity of the London Smoking Cessation Transformation programme. This is funded by public health teams across London, including Merton, with the aim for London to become the first smoke-free city in England by 2030 by getting more people to quit and change attitudes towards smoking. National evidence states smokers are 4 times more likely to quit smoking through treatment such as pharmacotherapy and directed behavioural support, which is highly cost-effective. A number of programmes are in place to support Merton residents stop smoking, which are commissioned and delivered by organisations at local, regional and national level. Everyone's Health is one of the Public Health Commission local stop smoking services designed and delivered as a tiered stop smoking service. Merton's stop smoking interventions focus on self-care, which is an approach that provides easily accessible advice on how to stop smoking and the promotion of websites, evidence-based tools and applications. Brief Support is a universal stop smoking offer based around the active promotion and signposting of residents not eligible for the targeted service to the national NHS smoke-free programme and works in partnership with providers who are able to deliver brief support and facilitate access to nicotine replacement therapy, such as community pharmacy. And specialist support, which is the delivery of a gold standard targeted and local stop smoking service for women who are smoking whilst pregnant, residents with poor mental health, those residents with respiratory disease and young people. The service is able to use discretion in the use of the criteria where reasonable. The interventions that Merton provides, including the gold standard targeted approach, target people that smoke and live in social housing via our range of providers, such as Alan Carr's Easy Way, which is the one-day psychological and behavioural support without quit aids, such as medications, vapes, and NRT. Everyone Health, which provides the 12-week support, and the Smoke-Free app. People living in social housing may have had previous failed quit attempts and perhaps additional barriers where smoking may be more acceptable in their social networks and communities, which could make it harder to quit. Merton is targeting smokers in both routine and manual occupations and social housing, working with boroughs across South West London. There is also a focus on working with young people who live in social housing and who are smokers. Marginalised groups may also be from ethnic minorities who face language barriers, with a large proportion in routine and manual occupations, and smoking is considered a norm. Smoke-Free Merton focuses on a range of interventions for targeting smoking more specifically. Merton is also using the Smoking in Social Housing toolkit provided by ASH, known as Action on Smoking Health. This toolkit is being used by housing staff to equip them to provide very brief advice and signpost tenants to stop smoking support. As the local data has offered insight into what interventions could additionally be offered and possibly tailored to very specific groups, the borough has looked for examples of good practice elsewhere and remains open to learning from other local authorities and approaches that prove to be effective. Capturing data around all of this helps to form a picture around the impact of interventions against other areas and nationally. And while as public health professionals, we may feel that there is always more that can be done, it is so important that we glean as much information from the data we have access to as possible. I hope this has given you an insight into the work we are doing in Merton, how we're using the data and the evidence to deliver interventions, and how we are learning from others. Next slide, please. I have added in a slide which contains some useful information on the areas I have talked about. Next slide, please. Happy to take any questions and comments and to let you know that there will be a slide pack that will be circulated. Thank you for listening.
Thank you, Samina. Oh, we've got a hand straight up there. Marie. Do you want to ask your question, Marie? Was that a... Marie's not coming off mute. Marie, was it a question or was it a hand raised by accident? Okay, we'll move on. And I guess oh, Marie hasn't got a mic. If you want to type your question into the chat, Marie, that's absolutely fine. And then we can make sure that we can read that out. Sign language, wonderful. We're communicating, wonderful thing. Samina, I've got a little bit of a question just while others are catching their breath and sort of taking in all of the information that you've imparted to us. Do you find that people understand the data? Is there a part to play in actually explaining it and putting it into lay language so that they can get the story behind the meaning of those, that essentially a lot of what you presented is quantitative information?
Thanks, Nicola. Yeah, you do have to actually go through the data a lot. It's about presenting that picture, because you can look at a measure and just think, oh, well, that's that about that measure. But there's a whole, it's telling that whole story. So the other measures that create that picture. And it's a bit like when I presented the data with the maps and everything else, it's that whole story of what's actually happening in the borough and that wider context. So you do need to explain about the actual quantitative side. And sometimes, you know, people can look at things like confidence intervals and things and think, oh, that means that, but it's not really. It's actually similar to another borough or similar to London or England. And then also about taking into account the literature and the qualitative information, which gives it that richness, and also information from the voluntary sector, so that voice is very, very important to hear from residents about how they're feeling and what their perceptions are. And I gave some examples or touched on it on the physical inactivity side. So it's very, it does take time to, you have to sit with people. You can't just throw data at them. You've got to talk them through it and explain what it means. So yeah, it's a really helpful question. Thank you.
Super. We've got lots of thank yous and things like that coming in on the chat. And we've got a question to do with Merton. So Samina works at Merton Council and was really keen to present those approaches, but just in terms of all of our research active local authorities. So we've got the HDRC network, we've got local authority research practitioners, and we've also got a lot of local authorities that are research active in their own right as well, and health as such and well-being is such an important aspect of all of the things that they do. Christopher, do you want to come in with your question?
Yeah, amazing presentation, thank you. Just wanted to ask, and I know you sort of caveated the presentation by saying that it was the data side of things that was influencing policy that you were focusing on, but I was just really interested to see, to ask to what extent you knew of the kind of reaction to, I'm actually from the environment and circular economy side of local government, but I work really closely with public health, so I'm really interested to hear to what success you've had in permeating the different the different kind of barriers across into green space health interventions, activities in parks, and also the active environments guidelines, to what extent in terms of planning and planning and active travel sort of interventions that you've had sort of permeating those kind of barriers, if you like, that sort of exist between departments.
Yeah, no, thank you, Chris. That's a really, really valid question, a really helpful question. So the annual public health report that we've just actually launched, and it's on physical inactivity. So we worked very closely with our environment team, with cycling and transport, looking at their strategies. So there's a link into the slides, which will give you that very broad information around what's in the report on those. So we did work really closely. We had their input on the annual public health report. So it's a public health report, but we've got environment involved in there, green space, and we all came together and we got a steer from them. So when the papers and that went and the report went to our departmental leadership teams and to the executive directors, so we've got that place representation. We had the environment executive directors there to input, and then obviously colleagues working within their departments inputting into that, because what we've got is we've got the Borough of Sport as well at Merton Council, if you want to look that up. And that feeds in very much with the environment side of things with this report as well, on physical inactivity, the environment and all of that. So we've got a whole section on that in itself where they've inputted. So we did have a very good relationship to work with them and get their input in a nutshell.
That's brilliant, thank you.
I think we've got just a minute and a half left. So there's one more question in the chat from Katie, and she's asking about linking in with local regional research delivery networks, and if you do that, Samina, and others do that. So, I mean, if you use that as a particular organisation, so we haven't linked in with a particular organisation, but obviously for all these the three examples that I've given you, we do work. We have inputted a lot from research. So we've done our own research. We've looked at research. So, for example, the annual public health report, we had about 4 or 5 chapter leads working on the different sections. And we've used research to input into that. So it's not just been the quantitative data, it's actually been doing sort of literature searches, working with colleagues in the NHS, for example, where we've got a research department, and actually getting their inputs on certain aspects where it's a sort of health and research side of thing that we need input on. So even though we haven't worked with particular organisations, we are doing the research to sort of inform the strategy, and it's not just based on quantitative information.
Thanks
Katie,
for that.
do you want to quickly come in, last few seconds?
Yeah, no, thanks for that. So one of the things I do, I'm a community settings lead for Lancs and South Cumbria for the Regional Research Delivery Network and social worker. And I think lots of stuff's about research delivery, but they're very aware that research delivery happens in hospitals, not with communities. They're not really addressing health inequalities in research. And I'm just thinking with what you've done in the evidence is really, really important. And it's stuff that we're aware of, and I think aware of in regions, but you've got some really tangible data there. But also if you're linked in with communities, that's where the NIHR Regional Research Delivery Network can struggle with sometimes, is how can they bring sort of agile delivery teams or recruitment to people that they often can't reach. So it might be worth linking in with whoever your community settings lead is, or I can find out for you if you want. I can put my email address in the chat if that would be helpful. Just thinking about another avenue of linking between, because you're in there and they're probably not.
Yeah, no, thank you. That will be really helpful. Yeah, do leave your details. And I forgot to say that we've just got the go-ahead to recruit to a LARP. So we will have somebody that's working on the research side of things within the public health team. We just literally got the go-ahead on that. I think it was last week. So we will have a research representative, and I think the aim is to focus on wider determinants and some of the work we've done in our health and wellbeing strategy and on our JSNA as well, and focus on some of those areas a bit more from a research perspective. But yeah, please do leave your details for me.
Yeah, I just stuck it in. I think really great work. It's really, and we've got a lot up in our areas as well, and we're linking really well. I think they're fab. So good luck with it all.
Fabulous to hear. That's wonderful. Well, I'll draw things to a close now. Thank you, everybody. Thank you so much, Samina, for the presentation and all of the really useful and interesting information that you shared. And thank you very much, everybody, for your attendance. And please look out for the next webinar in our series. We hope to see you all soon. Thank you. Take care. Bye-bye.